Since I was told to try to speak 3 languages, so we'll make it more polyglot, English, Spanish, and Polish. I guess at the beginning I would like to ask the audience, how many of you are native Polish speakers? Okay, a lot. How many of you can speak Polish at the level C1, B2? And are not Polish, okay. How many of you can speak Polish like B1, A2, so I can use it accordingly? Okay, so a lot of Polish speakers, cool. Okay, at the beginning I would like to say that since this is the real case from our department, my name is Tristan, by the way, I'm a neurosurgeon. I work in the Medical University Hospital in Wrocław. This is the real case, real patient, so I have his written and also recorded consent for me to use, to present this case to you during the Polyglot gathering. So, I guess we should begin. Polyglot and a brain surgery, what do they have in common? Well, I guess in most cases, hopefully, absolutely nothing. But polyglot, like every other human being, has to use brain, right? Actually, we all have to use brain to do anything, absolutely anything. To hold this hand, I have to use my brain first. So there are a few questions. Does the brain of the polyglot looks exactly the same as the brain of a not polyglot? Do we have some specific areas responsible for specific language when we learn them as a polyglot? And especially, what happens to a polyglot brain when it doesn't work correctly, or when you have some kind of trauma, stroke, or infiltrating tumor, like in this case? Bueno, voy a empezar en español. Creo que al inicio tenemos que hacer un pequeño recorrido por la anatomía del cerebro humano. Yo no he hablado desde hace mucho tiempo, pero entonces lo siento, voy a hacer muchas faltas, pero voy a intentarlo mejor. Y aquí tenemos un hemisferio. Cada cerebro tiene 2 hemisferios. Esto es el hemisferio izquierdo. Y en el hemisferio tenemos lóbulos. Aquí tenemos un lóbulo frontal, que es donde se encuentra una corteza motora primaria, responsable por iniciamiento de los movimientos voluntarios. Entonces, por ejemplo, si muevo mi mano izquierda, yo estoy usando este impulso, inició en el lóbulo frontal lado opuesto, entonces en el lóbulo frontal derecho. Tenemos el lóbulo parietal, que es exactamente la misma cosa, pero con los sentimientos. Entonces, si me duele mano derecha, yo lo siento con el lóbulo parietal izquierdo. Tenemos un lóbulo temporal, muy interesante para nosotros con este ejemplo, con este caso, donde se encuentran las áreas también de la memoria, del habla y de corteza primaria auditiva. Y el lóbulo occipital, donde se ve, se dice que se mira con los ojos, pero que se ve con el cerebro, con parte occipital, con el lóbulo occipital. Lo que es muy interesante para todos nosotros es que donde se encuentran las áreas de habla, como somos todos políglotas. Creo que esto es interesante. Y tenemos 2 áreas muy principales que están descritos en todos los libros, todos los manuales de la escuela primaria y secundaria. No es nada único, nada nuevo. Tenemos un área que se llama área de Broca, que se encuentra en giro frontal inferior en el hemisferio dominante. Cada persona tiene hemisferio dominante. En la mayoría de los casos, 80 o 90, no estoy seguro ahora, esto es el hemisferio izquierdo. Todas estas personas normalmente hacen todas las cosas con la mano derecha. Esta área fue descubierta por un anatomista, un médico también, Pierre Broca, que estaba examinando los cerebros en los pacientes que tenían alteraciones del habla y ha notado que todos estos pacientes tienen alguna cosa, algún tumor, hematoma, en la específica región, en la región de este giro frontal inferior del dominante hemisferio. Últimamente, al inicio se decía que esto es el que área de Broca es responsable de iniciar los movimientos que producen el habla, pero ahora creemos que es una cosa un poco más compleja, que su función es un poco más compleja de esto. Esto es eso. Entonces, otra vez, tenemos un hemisferio izquierdo, lóbulos frontales, y en la parte inferior, giro frontalis inferior, tenemos área de Broca. ¿Y qué pasa cuando algo pasa con esta área? ¿Qué pasa cuando tenemos algún daño, algún tumor, o después de trauma de cabeza o hematoma o algo así? ¿Cómo funciona este paciente? ¿Qué tiene? ¿Cómo habla? Y ya sabemos que este paciente pierde la capacidad de producir habla correctamente. Él no será capaz de hablar usando todas las partes de frase. Por ejemplo, va a usar solamente los sustantivos, va a hacer muchos como yo cuando hablo demasiado tiempo español. También se repite muchas veces. Usará las palabras que tienen significado similar o suenen de manera similar. Por ejemplo, aquí tenemos un ejemplo, yo escribí en inglés. So, okay, for example, if you ask the patient something, and what did you do last night? What did you do yesterday? He won't be able to use the whole sentence. He will just be able to say 3 words. For example, beer yesterday, friend. And that would probably mean that he had some beers last night. And he uses also, like I said, words which are similar about sounding or about the signification. For example, if he would like to use the word sword, he may use the word world, which sounds similar, or he may use the word knight, because he associated sword that knights have swords, and he associated that with knights. This is how it looked, that kind of the patient. Bueno, la segunda área, también muy bien conocida, descubierta por Karl Wernicke, un alemán neurólogo, psiquiatría, que en 1864 asoció un daño de la parte específica del cerebro, de parte posterior del giro temporal superior, con un trastorno, la alteración del habla caracterizado por no entender absolutamente nada, pero producir muchas palabras que no tienen ningún sentido. Cuando hablamos de área de Broca, el paciente sabe y entiende exactamente qué nosotros decimos, y él sabe que no es capaz. Esto es muy frustrante para él. Él no es capaz de producir habla, pero entiende todo. En el caso de área de Wernicke, de aphasia de Wernicke, el paciente no entiende absolutamente nada, habla muchas cosas que no tienen ningún sentido, muchísimas palabras también repetidas muchas veces, y no tienen ningún sentido, y no entiende absolutamente nada. Okay, my Spanish is over, definitely. So those are the 2 main ones, which everyone don't have to be a neurosurgeon to know that, because it's like in the high school. But being thankful to the investigators from Yale, we do know right now that there's a little bit more than that, than just 2 areas in the brain. They performed, before day surgery, awake surgeries, they performed using the fMRI, which means functional magnetic resonance imaging. This is the pretty awesome type of MRI which evaluates the blood flow on particular parts of the brain during some kind of tasks. For example, if you count, if you do math, if you play chess, if you speak some weird languages, the different part of your brain activates. The blood flow in different parts of your brain increases. And functional magnetic resonance can evaluate that. And using this, they had some patients, they put them in the fMRI, they were of course awake, and they were speaking, and they were in language, I guess in just one language, but they were able to see which part of the brain are being activated, where the blood flow is more than the other part. And we do have some more. The first one is called Exter's area, critical involved in transforming phonological representation of words into the motor commands for producing the written forms. You can see all of them, like here Exner's would be somewhere, I guess somewhere here. We have Angela Gyrus, particularly involved in reading and transitioning between written and spoken forms of language. Stimulation here can interrupt handwriting, causing unintelligible writing or repetition of words. And we have the basal temporal language area, which stimulation over there can cause disruption of a range of language tasks. For example, visual and auditory naming, auditory comprehension, reading, repetition, and speech. Those are all those areas which have been activated while those tasks using the fMRI. So a lot. No dobra, chyba spróbuję coś powiedzieć po polsku. Postaram się mówić powoli i wyraźnie, żeby nienaturalni Polacy również postarali się zrozumieć. Nasz przypadek to 60-letni mężczyzna, urodzony w Holandii, więc holenderski jest jego językiem naturalnym, który mieszkał wiele lat we Francji i kiedy go zapytaliśmy, jaki język uznaje za swój drugi, to mówi, że francuski oraz angielski. Jak myślę, większość Holendrów od małego uczył się angielskiego, więc używał go każdego dnia w pracy i w życiu codziennym oraz mieszkał we Francji wiele lat, z tego też tytułu, bardzo dobrze mówi po francusku. Więc te dwa języki uznaliśmy, że mówi w nich najlepiej i te dwa języki monitorowaliśmy w trakcie zabiegu. Uznajemy, że mówi w nich na poziomie C1, C2. Ożenił się z kobietą z Ukrainy, która z kolei mówiła troszeczkę po rosyjsku, ukraińsku, troszeczkę po polsku i tak B1 francuski, A2, B1 angielski. No to co zrobił nasz pacjent? Oczywiście nauczył się rosyjskiego tylko po to, żeby móc funkcjonować ze swoją żoną. I rosyjski uznaliśmy u niego, że jest na poziomie B2, C1. Pacjent zgłosił się do neurologa, ponieważ z powodu zaburzeń pamięci, takich nietypowych jak na swój wiek, ponieważ zapominał notorycznie najprostszych nazw przedmiotów oraz imion członków rodziny. Miał bardzo dużo problemów z pisaniem oraz praktycznie nie rozumiał tego, co czyta w żadnym języku. Umiał wymówić słowa, ale absolutnie nie rozumiał tego, co czyta. Nie miał żadnych innych objawów neurologicznych i zrobili mu rezonans magnetyczny. Well, I guess I don't want it to be all about neurosurgery, but and it's not an advertisement for the software, which is here. Nobody has paid me anything, but it is kind of cool. You must know that the surgery actually starts one day before the surgery, when we plan the surgery. And like you can see over here, this is the magnetic resonance. There are three parts of it. The first one here, it's called the axial plane. It's like you cut the head, something like that, and look from up. So those will be anterior part, posterior, right, and left. This is the coronal side, when you cut the head like that and look from anterior part. So this is right, left, up, down. And this is the sagittal plane. If you, like an arrow, cut the head like an arrow and look from the lateral part. So that would be anterior, posterior, up, down. Well, I guess you don't need to be a neurosurgeon to see that there's something wrong with this case, right? There's the huge tumor infiltrating in the temporal part of the hemisphere left, which is in this patient the dominant hemisphere. This software is pretty cool because we can actually like paint everything, highlight with different colors, everything. It helps us a lot during the surgery. It gives us the view on the microscope afterwards to be sure how many millimeters the cortex do we have to cut, how many millimeters away we are from corticospinal tract and stuff like that, which is kind of cool nowadays, but I'm going to focus on that too much. We also can build the 3D model of the head of the patient in order to prepare ourselves how we'll flex the head before the surgery to do the skin incision. For example, like in this case, the patient has to lie on his right side, so we can appreciate the left temporal lobe. We can add the things we have just painted. That would be the temporal lobe. We know where it is exactly on the skin because this is all based on the MRI. The software is pretty awesome. We can do the cutting, so we can measure how many millimeters of the cortex underneath the skull. How many millimeters do we have to cut in order to reach the tumor? Everything of this is possible using the software. Now we can add another structure, which is the tumor. We can see that the tumor lies underneath, just below, underneath the normal tissue of the temporal lobe. Again, we can do the cutting, see from different angles, and stuff like that. We have to be prepared for though exactly where the vessels are, where the nerves are, everything. Another added object, I didn't tell about that because normally the Broca and the Wernicke area are supposed to be connected by the arcuate fasciculus, which is here, but it's not that important. And final view, when I also added the primary motor cortex, which is highlighted over here, and the whole brain over here. So that would be the position of the patient during the surgery. And right now we are prepared, I guess. Yeah, the main question, I guess two questions which comes to mind of not medical persons. Why the hell would you do the brain surgery when the patient's awake? And does he feel pain? Well, I don't know, maybe you've seen the movie Hannibal, when there was a weird scene that the Hannibal cut off someone's head and was feeding the guy with his own brain, and he didn't feel anything. Well, it is actually doable, I guess, but yeah, brain itself doesn't have any pain receptors, doesn't feel pain at all. So you can do whatever you want with the brain. The patient won't feel any pain, but he, of course, if you cut too much, he will reveal symptoms, neurological symptoms. The main indication for surgery when the patient is awake is exactly what I've just said. What I said is the brain tumor infiltrating the eloquent area of the dominant hemisphere. You won't perform the awake surgery in non-dominant hemisphere, but you will do it the dominant one. Because why? You want to know if you damaged the patient. For example, you remove the tumor, remove the tumor, and you don't know if this is what you're looking for is still a tumor or it's just a normal tissue. And if patient is sleeping, you won't be able to know if you actually did the damage to the patient. Go more or not, go more or not. And that's why the patient is awake and he can talk to you. And when he stops talking, when you have a speech arrest, for example, you may know that you are pretty too far and you should stop the surgery, for example. This is the main indication for the patient to be awake during the surgery. Everything else does feel pain, of course. So before that, we have to perform the local anesthesia to anesthetize the skin, the muscles, the underskin tissue, the bone itself, and the dura, because it's not like in those stupid movies when you just remove the skull, you already see the brain. No, it's not like that. You see the dura, which covers just the layer which covers the brain, and it absolutely feels pain. But when you cut the dura already, open up, you can see the brain, and everything's fine. The patient won't feel pain anymore. That's the real picture from I guess it's not our clinic. I wasn't present there yet. Just not the speaking. For example, when the patient is a guitar player, professional guitar player, and his main goal, like he said, was, I want to still play guitar after the surgery. So what can we do? We make him play the guitar during the surgery, and we also should have someone who recognizes if he's playing well. Yeah. We also had the chess player who wanted to play chess afterwards, but we are too stupid to know if this is he did a blunder or what. It would be too difficult to play chess on him, speed chess like the Blitz during the surgery. But playing guitar, yeah, absolutely no problem. And he's playing guitar and we're doing our stuff, everything's happy. How do we evaluate the patient? Like we need to know, we need to have like the basis, right? So first of all, he has to speak with a psychologist. Psychologist can evaluate if the patient is likely to survive, because a lot of people, someone's doing weird things with your brain. He actually can hear the noise while cutting the bone, which can be very stressful for people. So the job of the psychologist is to evaluate if the patient is capable of managing that. If he said that, no, sorry, it will be disaster, don't do it awake, we don't do it awake. Afterwards, in this case, we wanted to know how are his language abilities. We don't speak Dutch. No one in our clinic speaks Dutch, so I had to find a native Dutch speaker so he can evaluate his Dutch abilities. We managed to do it in English, French, and Russian. And with the free conversation, it seems like he was totally okay without any problems. He did some small mistakes, but not like inappropriate mistakes. What is inappropriate grammar? For example, if I do mistakes while writing in Hungarian, it's not a big deal, right? Because Hungarian is crazy in grammar. But if I do mistakes in writing Polish, okay, maybe not the good example, because to be honest, Polish people don't write well in Polish. But you know what I mean. If I do some stupid mistakes in my own language, that's inappropriate grammar, right? Logical or lexical mistakes, we're looking for this during the conversation. And especially counting, what you will gonna see during the surgery. Patient has to count to 10 to 20, name the names of the week. And before the surgery, he did it absolutely perfect without any problems, all those languages. So we had like the basic stuff. And naming object. And there was a problem here because we gave him like pictures of 20 objects, and he wasn't able to name them. This part of his brain was already probably lost. For example, he saw the picture and he was explaining what it is without telling the name of it. It was like a pen, like a telephone. Well, it is to write and to understand written word, and he wasn't capable of naming it. He gave like 3 and 20 in this particular language. So it's not that much. Tumors are already pretty big. Okay, I hope nobody will pass out, I guess. Do we have a doctor on the audience? Cool. So you would do the job if someone pass out, okay? Okay, can you put the video? I guess it's a problem here. So, yeah, this is, I don't know why it's like that. You have the brain, like, okay, the patient is already awake. This is the view from the microscope. So I am already, yeah, we can add everything which I have already described. We can add the painted tumor, which is highlighted over here in the red. So we see that tumors underneath the normal tissue of the temporal lobe. Over here, that's the frontal lobe. And I use the bipolar probe in order to touch the brain for 3 seconds. I'm counting that. And the neurologist is putting electricity to the brain. It's not too much electricity, it's just like a few milliamperes. It won't cause any damage to the brain, but it will activate the brain. And while touching the brain, he's counting. And we are in several languages. You're gonna see that in a few seconds. And we are looking for the spots where he will arrest the speech, when he will stop speaking, stop counting to 10. The most important parts are, of course, where the tumors will be here, but since this is the frontal lobe and we are expecting that at least Broca area is somewhere here, we do it mostly in here. And when we find it, I found something here, we just add the cotonoid over here. I wanted to paint the cotonoid in the flags of the countries of the language, but it wasn't stellar, of course, so they didn't let me. And especially the place when you want to cut the cortex, we have to map the brain over here. Again, 1, 2, 3, and he's speaking 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, etc. 1, 2, 3, 4. And we're looking for him to stop, because if we actually manage to put on the right spot, he will stop immediately. So you can see that. Yeah, I'm holding the probe, and a professor of our clinic is all their devices. Go here, everything on the same place. And like I said, when we find something, we add the cotonoid on this place, so we can know that we should not touch it during the surgery. I also have like the view, because like I said, this is already after magnification and the microscope. On this side, I can see the MRI and all the painting structures, so I can know where am I. This is called neuronavigation, based of the pre-operative MRI scanning. It can take long. Of course, in this particular case, we did it more or less like 20 minutes. Of course, I won't show anything, just the highlights. And the patient wasn't cooperating well. You're going to see in the next movies when he speaks, he doesn't speak very precisely. Probably the tumor was already too big. And yeah, this is how it looks like. And he wanted to stop, like after a few minutes, he wanted to stop. So of course we stopped, because we don't want any disaster if he just tried to stand up, or it may finish as a disaster. So whenever the patient wants to stop, he can take it, he cannot take it anymore, we just stop. But we did manage to do something. You're gonna see that in the next videos, I guess. Yeah, again. Afterwards, you're going to see the picture of all those cotonoids, which I found something. Okay, next one. No, not this one. Yeah, English. And I hope the sound is okay. Really hope that. So this is the patient. It's not connected, right? Before you see that from the microscope, the movie directly from the microscope recorded, and this is just the guy recorded with his phone, right?
And a bit louder.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Again. Martin.
1, 2, 3,
Yes.
5.
1, 2, 3. And at this point, I touched the particular part of the brain with the probe. I remember that, and he stopped immediately. And after I switched off the electricity, he was able to speak again.
Once again, sir.
1, 2, 3, 4, 5, 6.
Not very precisely, I know. But you have to trust us. He was right now correctly. So we found something in English. Dutch, I don't know if there are Dutch speakers here, I don't know.
Martin, ik ben hier, Daan. Kun je nog tellen in het Nederlands, van 1 tot 10? In het Nederlands? 1. In het Nederlands.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Heel goed. Nog een keer graag. Martin, ik ben hier, Daan. Kun je nog tellen in het Nederlands, van 1 tot 10? In het Nederlands? 1. In het Nederlands.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Yeah, I'm touching, every time I put some 1, 2, 3, the probe with the electricity, and he's counting correctly. So I suppose we didn't touch the part which is responsible for Dutch speaking.
Nog een keer graag. Van 1 tot 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Not very loudly, but yeah, I guess the sound was better.
Is he counting well? Ja, hij is counting well.
Still counting.
Yeah, translator said he was counting well.
1 tot 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
The last part is not good.
Okay. Teraz po angielsku sami. Now in English, the same place.
That's interesting.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay.
Jeszcze raz dłużej trzymaj.
Yeah, he stopped or he did a mistakes while finishing counting in Dutch, but while touching the pop one spot. But when I touched exact the same spot, he speaks perfectly in English. So he stopped in Dutch, but kept speaking in English. And we also did French. For Russian, we didn't have time because the patient wanted to stop.
Est-ce que tu pourrais compter de 1 à... Est-ce que tu pourrais compter de 1 à 10 en français? Martine, tu m'entends? Martine, tu m'entends? Est-ce que tu pourrais compter de 1 à 10 en français? 1, 2...
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Myli pod koniec. Encore une fois.
1, 2, 3, 4,
En français, Martine. Martine, tu m'entends?
Yeah, while he was, I guess, pretty stressed, he unintentionally switched into English. So I guess it was his preferred language while being stressed. I think at this point he's already stressed, and we stopped like just a few minutes afterwards because he was very stressed and tired, and we didn't want to cause harm.
Est-ce que tu pourrais compter de 1 à 10 en
Encore une
français?
fois, pardon.
Martine, tu m'entends? Martine, tu m'entends? Est-ce que tu pourrais compter de 1 à 10 en français? Martine, tu m'entends? Martine, tu m'entends? Est-ce que tu pourrais compter de 1 à 10 en français? 1, 2...
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Myli pod koniec. Encore une fois.
1, 2, 3, 4,
En français, Martine. Martine, tu m'entends? On compte en français. De 1 à 10 en français, s'il te plaît.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Et encore une fois. De 1
Daj prądem. Daj prąd. Dawaj jeszcze raz.
1, 2, 3, 4, 6, 7, 8, 9, 10.
Absolutely stopped after cut, mumbling and saying nothing. So when I touched the particular spot, and this is the view afterwards. I guess we managed to map this. Those are the spots where the speech arrested in the particular languages, in this case of the patient. And afterward, I'm not going to show the resection of the tumor, of course, because it's not the topic. But yeah, after that, after 20 minutes, we have just started the real surgery, removing the tumor over here. And this is one day afterwards.
I don't know if I still remind the right way of talking English for
Yes, yes.
farmer.
This is like the second day after the surgery, and we would like to know how are your English abilities. But as far as I can hear, it's pretty well, right?
English is very easy because I think it is because it is simply the only language that I learned when I was in school.
Yeah.
Yeah, that's the only one.
What about the surgery? Do you remember that you were talking with us and stuff like that, or?
Only a few words.
Only a few words.
I only remember that.
Yeah, you were cooperating with us pretty well. We were happy about
that.
that.
You said that I'm tired and I want to stop.
Yes, that's correct. You did that a few times, but yeah, it's absolutely normal.
I guess the doctor also wanted to stop after 6 hours.
That's correct. Yeah, we were a little bit tired as well. Ok, alors maintenant je voudrais vous demander exactement la même chose en français. Oui, parce que c'est le deuxième jour après votre opération. Je voudrais savoir comment ça va.
Donc pour moi c'était très intéressant d'écouter le docteur qui m'a dit que... Non, le docteur qui...
Oui.
qu'il a l'impression que mon langue français il est plus proche de ce qui se passe dans le cœur.
Oui,
Pas dans la
pendant l'opération, nous avons demandé quelque chose en anglais, vous avez répondu en français. Et après l'opération aussi.
Je ne savais pas. Moi, c'est une surprise.
Alors, je crois que la langue française est très importante pour vous.
Je ne pense pas seulement pour moi, parce que quand il m'a dit ça, je pensais, oui, pathology. Je pense qu'ils ont, pas la première fois qu'ils ont dit que la langue française, c'est la langue de cœur.
Peut-être c'est ça,
Language from his
Это
heart,
très bien,
French.
nous sommes très heureux. И еще сейчас я бы хотел увидеть, как дела? Сможете что-то сказать по-русски сейчас?
Как dire, Russie, c'est un peu devenu plus difficile.
Yeah, he kind of forgot Russian after surgery, and he's giving answer in French. As I understood afterwards, when he was discharged, it came back to him, so he can actually communicate with his wife. But direct after the surgery, you see that he understood the question, but he started speaking French instead of Russian, which he was speaking without any problems before the surgery.
Значит, что сейчас говорите по-французски.
Русский.
А как называются по-русски дни недели? Сначала из что? Понедельник, а потом...
Понедельник, вторник, среда, четверг, пятница. Encore français?
По-русски.
Суббота, воскресенье. Oui, je me souviens bien sûr.
Вы все понимаете, что я говорю сейчас, что я сказал? Но это еще очень трудно говорить
Wszystko rozumiał, ale zamieniał języki, nie?
Русскую речь.
Еще не очень получается включить на французский язык. Il est présent. У меня внутри есть вот это русский язык, mais je dois encore français.
Yeah, okay, that's...
Ce matin, c'est...
So he was doing pretty well after, like one day after the surgery, pretty cool. So, conclusions? Neurochirurgia is zajebista. That's the main conclusion, which neurosurgery is awesome. Human brain also is pretty awesome and still very mysterious. We don't know that much about the brain anymore, even though we do the surgeries. The patient diagnosis came a little bit too late. Definitely the tumor was too big. Probably if it was a little bit smaller, maybe he would stand more during the surgery. Maybe we can remove it all. And we are able to catch a few spots which stimulation arrested the particular language, which is the main topic of today's presentation. We managed to find a particular spot and stop it with the bipolar probe using the small amount of electricity. And I guess that's it. We didn't discover America, but I think it was pretty awesome. I believe the further investigations should be performed, but of course, there are not too many polyglots on the earth, and I hope none of those polyglots have brain tumor, and specifically brain tumor which is suitable to perform the awake surgery. So because of the lack of the patient, I guess further investigation might be difficult. Thank you very much. Okay. Are the areas for each language the same? We have no idea. I guess the language which your mother tongue, I guess it may be in the different part than the languages which you have learned during your whole life, but if they are the same in every individual, I don't think so, to be honest, but is there a pattern over there? We don't know. Glioblastoma, the second question, the most malignant one, unfortunately. In this case, still life expectancy, even after correctly performed surgery, is 6 months. We still consider glioblastoma as an incurable disease at this point. Have I noticed the recent research On speakers of artificial language by what Smith McGovern is, I don't know, I'm not familiar with that, unfortunately, but I would love to be, if someone can catch me, can drink some vodka and talk about that. Are there many other polyglot neurosurgeons like you? Should polyglots? I mean, yeah, if you have some brain tumor, you feel welcome to call me, right? It will be amazing. Of course, I don't want you to have the brain tumor, but if you do, of course, feel welcome to contact me. In any case, I don't know if, I guess we all speak English because we have to learn in English for our exam and stuff like that, and do the researchers in English, but I don't know about a lot of other neurosurgeons. Do they speak other languages? Probably, yeah, but I don't know how many, and if we can consider them of the polyglots, I don't know. When the patient wants to stop the surgery, but you couldn't. Next question, I mean, depends, because we are not asking if he wants to stop the whole surgery. If he wants to stop being awake, this is what we are asking for, and we respect his opinion, because he wants, I cannot stand, doctor, I cannot stand it anymore. We just anesthetize him and he's falling asleep. And we can resect the tumor, continue resecting the tumor, but without having the advantages of speaking to him, right? So we decide when do we finish the surgery. Now, of course, not the patient, but the patient can specifically request that he cannot stand anymore being awake, and it can cause disaster, so we should put the patient back to sleep at this point. What happens to the empty room after removing the tumor? Unfortunately, in case of glioblastoma, it will grow up again. But normally, when the tumor is growing up, it causes the compression to the brain. So yeah, when you remove the tumor, it's like the hole in there. But the brain, which was at the beginning on this place, at some point will go back and cover this empty room. I don't think so. I think all the brain looks exactly the same. I mean, if you drink vodka 60 years, it looks differently, but like normal human being, yeah, all look the same. It depends. The second question, if someone had to remove a part of the brain responsible for a language, do you think that person can recover that language ability by compensating with a new part? Very good question. Sometimes we have troubles. For example, there's a big tumor, patient's awake, we're trying to resect it, and at some point he stops speaking or stops moving hand, and we have to leave the part of the tumor untouched. We cannot resect it anymore. And we finish the surgery. If this is not the malignant one, the benign, the patient can live with that several years afterwards. But we have found out that the part of the brain which was responsible for speech at the time of the first surgery, when you perform another surgery, the speaking abilities and the area where he arrested when he couldn't speak is not there anymore. Because of the flexibility of the brain, the area which could not be resected at the first surgery now is able, we can do it because the speaking part is in the different area of the brain. And this is kind of cool and fascinating. So yeah, the patient absolutely can recover. I guess everybody knew someone who had a stroke. So at the beginning he cannot speak and move his hands, and afterwards, after good rehabilitation, he can do it again. So yeah, absolutely he can. Did the patient recover? Unfortunately, we lost contact with him after a few months. I just knew he showed up with another MRI. The tumor regrew, but we didn't want to do the surgery anymore because it involved another area. And I guess he wanted to go to another clinic, but to this moment I don't know. Of course, depending on the tumor, if you have the benign tumor, you remove it and you cure the disease immediately, like for example meningiomas, which are absolutely benign tumors. But in the case of the absolutely the worst one, which is glioblastoma multiforme, it's the most malignant one, it definitely will grow back. No doubts about that. And like I said, it's still, till this day, considered uncurable disease. Another cool question, and I again feel bad that I must say I don't know, because it's a good question. I'd like to know the answer. I have no idea. Probably, yeah, but not sure. I don't know even how to check it. Local chemotherapy? No. Systemic chemotherapy in the tumor of glioblastoma. After the surgery, the patient should go the full chemoradiotherapy. I was not talking about the pain, actually. I was talking about his physical, mental state. We can, like you wrote afterwards, we can cover the pain. Pain is not a problem at all. They don't feel pain. If you anesthetize it correctly, do the local anesthesia, the patient won't feel pain, if you do it correctly. In every case, we have never had problems with too much pain and stuff like that. The problem is that the patient can be scared. Can get crazy after hearing the voice of cutting the bone, the skull, and he also hears our conversations. We have to be very careful about what we are saying. If we do something, oh fuck, and he hears that, and he says, what the fuck are they doing? So yeah, it may be a disaster if so we use help of the psychologist to evaluate if he's going to behave and cooperate with us. So, okay. No, okay, now I understand. Yeah, I guess we thought it wouldn't be necessary, but good point. He was speaking very precisely, maybe because of the mustache and stuff like that. Good catch. Next time I will shave the patient. Next question, another good question. Yes, and when I touched the particular part and he, for example, stopped in English, I didn't show like whole the movie because it was like 20 minutes. I immediately changed into other language in order to see if he also stops, like we had with the arresting the Dutch part and remaining good in English. But afterwards, yeah, I wanted to check it again afterwards and touch the same part, and he also like did some mistakes in this specific area. So I guess yeah. Yes, they have fixed head in specific clamps, so he cannot move his head. He can move everything else, but he cannot move his head. Have to be stiff and still, so we can do the neuronavigation. We don't do deep monitoring. In this case, we just do the superficial on the cortex. We didn't map, for example, when we cut the cortex and we try and remove the tumor, we didn't map it anymore. So just the cortex on the superficial of the brain. Yes, we removed like I would say 96-97% of the tumor, not the whole one. I guess, yeah, you could be, but maybe not should be. Depend on the hospital, depend on the surgeon, depend on the disease which you're having. But yeah, I guess, which is fascinating for me, patients don't ask too much. They never ask that much about the surgery. I'm very open to explain everything, how the surgery is going to be about. They just don't care. And so this is kind of weird. If you're gonna get some surgery, please ask the doctor what he's going to do, where the incision is going to be, what will he cut, what can you expect before, what can you expect after the surgery, what are the percentage, what is his experience. Do the asking. How do you know if remove all of them? Another good question. Sometimes we don't know sometimes if this is still the tumor, if this is just the brain. So when we are not sure, we usually try to stop. And we have other things with fluorescency and some neurosurgical tricks in order to be more sure, to be more convinced that this is actually still the brain tumor or not. But I guess I'm not going into the details right now. Maybe I will translate the question first for the not Polish speakers. You said that during the operation of the non-dominant hemisphere, you make the patient fall asleep. Doesn't it mean that you can actually harm some function of the patient? Of course we can harm, but in the dominant hemisphere, usually there's the speech abilities, and if you, for example, do the harm in the non-dominant hemisphere, in the same spot where in the dominant is the speaking abilities, you won't do that. So this is called not dominant because it doesn't have the most important ones. But of course, if you do some mass in the non-dominant hemisphere, you will cause harm to patient as well, but maybe not that much pain, not that much cause. We don't have functional MRI, sorry. Well, I guess we have operated. This was the first patient which we have monitored more than one language. So I guess this is my only experience with the brain of the polyglot so far. So I guess I cannot answer very well to this question. Haven't met anyone. Haven't met any like the polyglot after the stroke so far. But it might be interesting if you have some. I would be very happy to see him. Okay, I guess there are all questions. Thank you very much again.